So today we are talking about mesenchymal tumors. The other big group is melanin-forming tissue tumors, and just few words about tumors of the central nervous system. So let's start with mesenchymal tumors. Just to remind you that any kind of tumor have parenchyma comprised by proliferating tumor cells, and parenchyma determines the nature and evolution of the tumor. Also, any kind of tumor has supporting stroma composed of fibrous connective tissue and blood vessels. It provides the framework on which the parenchymal tumor cells grow. All tumors, benign as well as malignant, have two basic components. Let's start with mesenchymal tumors. The suffix "oma" is added to denote benign tumors. You know that from our lecture about epithelial tumor. Malignant mesenchymal tumors are named sarcomas. Sarcos means fleshy. However, some cancers are composed of highly undifferentiated cells and are referred as undifferentiated malignant tumors. Although this broad generation regarding nomenclature of tumors usually holds true in majority of instances, some examples contrary to this concept are, for example, melanoma is the tumor of melanocytes, hepatoma, carcinoma of hepatocytes, lymphoma for malignant tumors of lymphoid tissue, and seminoma for malignant tumors of testes, for example. And you know, leukemia is the term used for cancer of blood-forming cells. In ontogenesis, mesenchyma gives the beginning to connective tissue, vessels, muscles, tissue of musculoskeletal system, serous membranes, hematopoietic system. Mesenchymal tumors develop from connective fibrous tissue, fat tissue, muscular tissue, blood and lymphatic vessels, synovial tissue, mesothelial tissue, bone tissue. Also, as I said before, we have benign tumors, and we use the name of the tissue and plus suffix "oma". Malignant tumors, the name of the tissue plus sarcoma ending. There are also special terms, for example, desmoid or granular cell tumor. That's another kind of names. Look at this picture and you see very big variety of tumors. We see classification of tumors which is based on histogenesis. It means cells of origin of any kind of tumor, and on anticipated behavior, because we have here benign tumors and also we have malignant tumors for the same tissue. So non-epithelial or mesenchymal tumors from adipose tissue, the benign tumor, lipoma, and malignant one, liposarcoma. Adult fibrous tissue, fibroma, and fibrosarcoma for malignant one. Embryonic fibrous tissue we call myxoma, and the malignant tumor, mesenchymal. Cartilage gives histo-origin for chondroma, and malignant tumor, chondrosarcoma. Bone osteoma is benign tumor, and osteosarcoma is the malignant tumor. Synovium, benign synovioma and synovial sarcoma. Smooth muscle, leiomyoma is benign tumor, and leiomyosarcoma is a malignant one. Skeletal muscle, rhabdomyoma and rhabdomyosarcoma for malignant. Mesothelium, we call mesothelioma. Mesothelioma, it's malignant tumor. Blood vessels, hemangioma and angiosarcoma. Lymph vessels, lymphangioma and lymphangiosarcoma. Glomus, glomus tumor, only benign. Meninges, meningioma and invasive meningioma. Hematopoietic cells, they all malignant tumors. There is no benign tumors from hematopoietic cells, and we call them leukemias. Lymphoid tissue, pseudolymphoma is benign pathology, and malignant lymphomas, this is the biggest group of tumors compared with the benign possibility. Nerve sheath, neurolymphoma, neurofibroma, and malignant tumor, neurogenic sarcoma, and nerve cells, ganglioneuroma and neuroblastoma. Grossly, all sarcomas looks like a fish flesh. Please remember that sarcoma metastases are disseminated hematogenically, so via blood. Under microscope, for recognition and classifying tumors, the microscopic characteristics of tumor cells are of greatest importance. These features, which are appreciated in histological section, are as under: first, microscopic pattern, cytomorphology of neoplastic cells, for example, their differentiation and anaplasia, tumor angiogenesis and stroma, and at the end, inflammatory reaction for the tumor growth. Here on the right side of the picture, we see the piece of skin, the cross-section through a Kaposi sarcoma tumor nodule, which shows a classic pattern of such tumor, sieve-like pattern, intervening thin fascicles, seen mild to moderate nuclear atypia is acceptable, such as the elongated hyperchromatic nucleus in the central upper region. Look here, such cells and such nuclei. But marked nuclear atypia should prompt an expanded differential. Mesenchymal tumors have mesenchymal tumor cells arranged as interlacing bundles, fascicles or whorls, lying separated from each other usually by intercellular matrix substance, such as hyaline material in case of leiomyoma, cartilaginous matrix in chondroma, for example, osteoid in osteosarcoma, and reticulum network in soft tissue sarcomas, and other examples. Here, look, we see the osteoid areas and also tumor cells, which have cell atypia. And on the top, we see chondroma with we see some cells and matrix of the neoplasm. In leiomyosarcoma, grossly we see irregular margin. Look on the right, we see irregular margin, invading borders, and fish flash pattern. And histologically, we see, compared with the normal on the left side of the picture, we see examples of pleomorphism, so various structure, various pattern of the cells, sarcoma cells, and also we see the hyperchromatic big nucleus compared with the normal situation. Also, we see tumor giant cells and mitotic figures. Connective fibrous tissue cells. This is the first group of the mesenchymal cells we are going to discuss. Benign ones, fibroma, desmoid fibroma, dermatofibroma, histiocytoma, and malignant fibrosarcoma, dermatofibrosarcoma protuberans, or malignant histiocytoma. Look here on this picture on the left, we see firm, non-tender erythematous nodule on the finger of the baby. And the histology is quite characteristic for such tumor. It shows interplaced spindle-shaped cells and collagen fibers within the dermis, mild layer of the skin, and subcutaneous tissue under the skin. The cells include unusual inclusion bodies and are thought to be myofibroblasts. The cells take type that takes muscle fibers. Here on the picture, on the left side of the picture, we see the gross picture of the tumor, fibroma of the ovary, and the cut surface of the tumor shows the homogeneous white appearance. Benign stromal tumor composed of spindled, ovoid to round cells within a variably collagenous stroma. And under microscope, we see such histological pattern. Fibroma, there are two kinds of fibromas, soft fibromas and hard fibromas. What is the difference between two of them? Hard fibromas, also known as fibroma durum, consist of many fibers and few cells. And on the right side of the picture, we see soft fibroma, fibroma molle, consists of many loosely connected cells and less fibroid tissue. Look on the left, hard fibromas, and on the right, we see the soft fibroma. Here on the top of the right side of the picture, we see the small fibrous node with yellowish-brown color and localization, the skin of the legs, and under microscope, the benign tumor cells arranged with fibrous cells, fibrocytes, arranged with atypical pattern, but it is only tissue atypia. Here you see the malignant tumor of fibrous tissue, fibrosarcoma, which is dissected, and we see node without clear borders, appear well circumscribed but non-capsulated. and we call such a gross picture pattern as fleshy, sometimes hemorrhagic, white tan color. Under microscope, we see highly cellular fibroblastic proliferation in herringbone patterns. We see cells in columns of short parallel lines, with all lines in one column sloping one way, and lines in adjacent columns sloping the other way. Here you see one way or the other way. Cells have scant cytoplasm, tapering elongated dark nuclei with increased granular chromatin, variable nucleoli, mitotic activity present, often with abnormal forms of the pattern. Tumors of fatty tissue. There are two groups of such tumors, benign and malignant. Benign tumor, lipoma and hibernoma, and malignant liposarcoma, lipoblastic myoma, and malignant hibernoma. Here you see the lipoma, also cut on two pieces. It is well circumscribed, nodular, cut surface looks homogeneous, with fatty appearance of the tumor, and there are some hemorrhages in the tumor. Usually it is not big, less than 5 centimeters in diameter. Under microscope, here you see the picture on the right part of the slide. We see proliferation of mature adipocytes. Paucicellular fibroceptor can be present here. We see some septi. Fat necrosis is often found in larger tumors, and skeletal muscle fibers are infiltrated in case of intramuscular lipoma. Not here. Here also lipoma. Look, we see adipocytes, we see hyperemic vessels, and some fibrous tissue between lobules. Fat lobules of various sizes, which are separated by thin and thick layers of connective tissue. Hibernoma is a rare tumor of brown fat and consists of large round cells with granular or foamy cytoplasm with fat vacuoles. Here you see the microscopic picture of such tumor. Liposarcoma. Tumors are usually large, appear to be relatively circumscribed. Cut surface may be yellow, fatty, with interspersed fibrosepti, or maybe uniformly firm and white. Areas of necrosis and hemorrhage may be seen in high-grade tumors. Cut section of the specimen showing yellowish and myxoid areas. Here you see the tumor node. Sarcoma, the cut surface multilobulated, contains some solid areas and some areas of hemorrhages. Look, there are some hemorrhages, some dark foci here. All malignant soft tissue tumors appears macroscopically to be well encapsulated, but anywhere they are, of course, malignant ones. Under microscope, we see various kinds of cells here on the histological slide: mature adipocytes, atypical spindle cells, multivacuolated lipoblasts, embedded in a loose myxoid to dense fibrous stroma. All variants of liposarcoma may be seen. Well-differentiated or dedifferentiated liposarcomas are most common tumors. Here also we see liposarcoma. The photograph shows mature adipocytes and bizarre hyperchromatic stromal cells. Look, here they are. Amidst dense fibrocollagenous tissue. Here inset on the left bottom side of the picture shows atypical lipoblasts with scalloped nucleus here. Here it is. This is hematoxylin and erythrin staining and magnification 400. Now we go to tumors of the muscles. Benign and malignant. Benign leiomyoma, rhabdomyoma, granular cell tumor, we call it under name Abrikosov's tumor. Malignant tumors, leiomyosarcoma, rhabdomyosarcoma, and malignant granular cell tumor, malignant myoblastoma. Look here, we see the endocardium, and this is a rhabdomyoma node, the area of the tumor growth. Under microscope, myocardial rhabdomyoma, a tumor of polymorphic, large, round, or polygonal cells with glycogen inclusions separated by strands of cytoplasm extending from the cytolemma to the cell nucleus or spider cells. Here they are under number 1. In the cytoplasm of cells, as a rule, myofibrils are determined. Here you see tiny, tiny fibrils within the tumor cells. Here we see the example of the leiomyoma. Here you see the leiomyoma of the uterus, a big tumor node cut into 2 parts. We see the typical whorled tabulated pattern of the tumor. Under microscope, leiomyoma of the uterus. Again, we see the strands of the leiomyoma cells, and we see the tissue atypia, but cells are quite differentiated. The tumor built of smooth muscle cells that form randomly located bundles of different thickness. Here and here are the bundles of the leiomyoma cells. We have already seen rhabdomyoma of myocardium. Again, it's a bigger, higher magnification. A tumor of polymorphic, large, rounded, and polygonal cells with glycogen inclusions. And also we see tiny myofibrils within the cytoplasm of the cells. Here we see the gross picture of rhabdomyosarcoma of the uterus. We see a grayish pattern of the surface with some hemorrhages. Also, here the picture, as other sarcomas, looks like a fish flesh on the cut surface. Embryonal rhabdomyosarcoma under microscope with primitive round cells and occasional strap cells showed by arrow, with abundant eosinophilic cytoplasm and cross striations. Here you see such cells. Other picture, microscopic picture of the same pathology, rhabdomyosarcoma, sheet-like growth of pleomorphic round to spindle cells, and scattered large rhabdomyoblasts. Here they are, very big, large rhabdomyoblasts. Now we go to tumors from blood vessels. Benign tumors, hemangioma, capillary venous cavernous benign hemangiopericytoma, glomus tumor, glomus angioma, and malignant tumors from blood vessels, angiosarcoma and malignant hemangiopericytoma. Here we see the gross picture, the skin of a child, 3 months old, and we see cutaneous hemangioma. Such kind of tumor are quite common for babies. Hemangioma of the buccal mucosa. Deep lesions are well circumscribed and solid to cystic with dilated vessels and with or without thrombus formation. Maybe polypoid with a stalk, sometimes, not here. This picture we see the gross sample of the liver with a liver hemangioma, which is non-cancerous or benign mass in the liver made up of tangle of blood vessels, also known as hepatic hemangiomas or cavernous hemangiomas. These liver masses are common and are estimated to occur in up to 20% of population. Hemangioma is circumscribed, unencapsulated proliferation of irregular blood-filled vascular spaces lined by a single layer of endothelial cells. May or may not show lobular growth pattern with large feeding vessels at periphery. There are multiple subtypes of hemangioma. Please remember, capillary hemangioma more common, characterized by slit-like vascular spaces. By the way, here on such picture, we see a lot of tiny vascular spaces. Cavernous, characterized by dilated vessels, we see later, and mixed, the features of both capillary and cavernous. Okay, whereas here we see some big areas, and like in cavernous hemangioma, and tiny capillary vascular spaces on the other areas of such microscopic picture. And we have also anastomosing hemangioma, like a variant of capillary hemangioma. Here we see venous hemangioma. Look, cavernous hemangioma of the liver. The tumor is built up of many thin-walled vascular cavities of various sizes and shapes, lined with endothelial cells. Here, such areas. The cavities contain blood or thrombotic masses. The tumor is separated from the surrounding tissue by a fibrous capsule, like here, under number 2. Benign hemangiopericytoma. So here we see the proliferation of benign pericytes, and we have the only tissue atypia, but cells are differentiated, so mature cells. But other picture with the malignant tumor, angiosarcoma or hemangiosarcoma, and malignant hemangioendothelioma, various kinds of such sarcomas. intermediate between benign and malignant tumors, so locally aggressive and rarely metastasizing kind of tumor from the blood vessels, Kaposi sarcoma. Look here on the right side of this slide, we see the skin of the feet, which is thickened, edematous, purple bluish in color. This is vascular neoplasm caused by human herpes virus 8. Tends to be indolent but maybe locally aggressive, and it is quite often diagnosed in patients with HIV infection, Such pathology or Kaposi sarcoma, they have various stages, few stages like patch stage, plaque stage, tumor or nodular stage, and other stages. So, in case of first patch stage, we see dilated vascular channels dissecting through dermal collagen. Tumor vascular channels surround and entrap native vessels. May be very subtle in early lesions of the patients. Then goes plaque stage, more extensive, compressed, slit-like vascular channels, infiltrating deeper dermis areas, infiltrative proliferation of spindled endothelial cells. These cells may resemble fibroblasts. Spindle cells infiltrating and destroying occurring coils is very characteristic for such tumor. Then goes tumor or nodular stage. We see discrete nodules composed of intersecting fascicles or uniform spindle cells. Intervening blood fills spaces between spindle cells, slit-like spaces, longitudinal section, sieve-like spaces in cross-section, and intracytoplasmic hyaline globules may be seen. In all stages, we see mitosis common, but pleomorphism usually minimal. Rare, poor differentiated cases have severe pleomorphism, but it's very uncommon. Extravasated erythrocytes and hemosiderin also could be seen, and it is common finding in this pathology. And plasma cells reaction seen in most cases. Here the microscopic picture of Kaposi sarcoma, a tumor stage. This image demonstrates sheets of plump spindle cells without obvious channels of blood or extravasated red blood cells. So we see spindle cells and spaces with no blood. Angiosarcoma, as I said before, hemangiosarcoma, malignant hemangioendothelioma, various kinds of such sarcomas. Pathogenesis of angiosarcoma is characterized by a rapid and extensive infiltrating overgrowth of vascular endothelial cells. Angiosarcoma is a locally aggressive tumor with a high rate of lymph node infiltration and metastasis. Here you see the gross picture of the tumor, and under microscope we see atypical endothelial cells which proliferate and form such spaces which resembles in some areas resemble vessels, but they are not filled with erythrocytes, and they have no features of the normal vessels, normal histological pattern of the vessels. Tumors from the lymph vessels, benign, like lymphangiomas, and malignant tumors from lymph vessels, lymphangiosarcoma. Lymphangioma or cystic hydroma in a child of 6 months age when dissected on the cross section. We see here on the picture lymphangioma removed surgically from the left axilla. And look, the cut surface shows the spongy appearance of the lymph channels. Here, the bigger and the smaller lymph channels, which give such a spongy appearance to the cut surface of the tumor. And lymphangiosarcoma, quite seldom tumor, and appears as a result of chronic lymphatic stasis, such pattern like here on the right side of the slide. Now we go to bone tumors. Benign tumors, osteoma, osteoid osteoma, benign osteoblastoma, quite unusual name for benign tumor, osteoblastoma, but anyway, it is benign. Giant osteoid osteoma, giant cell tumor of the bone, osteoblastoclastoma, and malignant tumor, osteosarcomas. Here you see the osteoma of the oral cavity. Osteoma, benign bone-forming tumor composed of mature cortical type or less frequently trabecular bone, typically involving the craniofacial skeleton. Typically a solitary lesion, tan white, oval, round of polypoid pattern. It is firm, well circumscribed and attached to the underlying bone. Cut surface with dense compact bone or trabecular bone. Here you see osteoma grossly and under microscope. Osteoid, osteoma or osteoma, they are like synonyms. Develops both in tubal and spongy bones, more often in the bones of skull. Extraosseous osteoma occurs in the tongue and breast. Distinguish between spongy and compact osteomas. There are two kinds: lamellar bone pattern with Haversian-like canals on the top right, and lamellar and woven bone patterns with marrow spaces on the bottom. Admixture of mature lamellar and woven bone patterns with Haversian-like canals, which may have various sizes and shapes. And more often we see cortical type of bone architecture, less frequent trabecular bone architecture. Osteoblast, rimming bone are inconspicuous and small but can be prominent in growing lesion. Osteocytes in the matrix are small, not atypical and randomly distributed. Intertrabecular marrow spaces are filled with moderately cellular, loose fibrous stroma, and inflammatory infiltrates are typically absent. Osteosarcoma, here you see the cross-section of the bone, which shows high-grade osteosarcoma involving the distal femur. Most of this lesion was osteoblastic by scattered chondroblastic areas. Look here, some looks like the chondrum, and here some areas. So we see such a picture on the cut. Malignant tumor in which the cells synthesize bone, most common primary malignant solid tumor bone. Plasma cell myeloma is actually the most common primary bone tumor, but it's not a solid tumor. Many types of osteosarcoma that differ based on the tumor's location within the bone or on the surface of the bone, and the grade of the tumor, low grade, intermediate grade, or high grade of the tumor. 90% of osteosarcoma is conventional, so high grade intramedullary osteosarcomas. Here you see osteogenic sarcoma, the creamy tumor, which has involved the lower end of the femur and has broken through the cortical bone. Here it is. And caused elevation of periosteum. Here we see on the left side of this picture. This low-grade centrum osteosarcoma arose in the distal femoral metaphysis and invaded through the cortex and into the adjacent soft tissues. Here it is. We see on the cross-section of the distal femoral metaphysis. The same picture we have already discussed, osteogenic sarcoma. A creamy tumor affected the lower end of the femur, ruptured the cortical bone, and we see raised periosteum. Under microscope, osteosarcoma looks like here on the left side of the picture. Tumor cells are very pleomorphic, other words, anaplastic. Some are giant cells. Here we see the giant cells, and we see atypical mitosis. Here, for example, atypical mitosis. Here we see atypical mitosis. These cells produced osteoid, describing irregular trabecula, amorphous, eosinophilic pink. Here we see such areas. You see pinkish, intensive pinkish color of the areas with or without central calcification. No calcification here. But there are some areas of calcification. We see bluish areas here, the calcification areas. High-grade osteosarcoma with markedly pleomorphic neoplastic cells. Look, when we look at such picture, we see that the cells are so different in their forms, their features. So this is a very markedly seen pleomorphic features of the cells. Cartilage tumors, benign tumors, chondroma, chondroblastoma, or mixture with bone, osteochondroma, other words, bone and cartilage exostosis. Malignant tumor, chondrosarcoma. Osteochondroma on the rib, 22 years old, female patient. This is a common benign tumor that usually occurs in the area of epiphysis of the long bones. It is characterized by the presence of a distant cartilaginous cap, like here, such cap on the tumor, and these tumors easily excised. Chondroma X-ray picture and histological picture of the low magnification. Chondroma is a tumor arising from hyaline cartilage. It is dense. On the cut it looks like hyaline cartilage. Consists of randomly arranged mature cells of hyaline cartilage, enclosed in the ground substance and can reach large sizes. The most common localization is the hands and feet, vertebra, sternum, pelvic bones. A tumor located in the peripheral parts of the bone is an anhydroma, and in central parts of the bone is enchondroma. So here we see echondroma on the X-ray picture. Chondrosarcoma differs in polymorphism of cells with atypical mitosis, chondroid type of interstitial substance, foci of osteogenesis, mucus, necrosis. It is characterized by slow growth and late metastasis. Now we go to tumors of the serous membranes, benign tumors. Fibrous mesothelioma, adenomatoid tumor, and malignant tumors, we call them epithelial mesothelioma. Mesothelioma of the pleura, male patient 67 years old. Look, here we see tiny piece of the lung left, and this is the growth of the tumor in pleura. This vertical section of the right lung shows how pleural mesothelioma causes thickening of the pleura and involves the entire lung and mediastinum. Left-sided mesothelioma of the pleura covered with thick, white, hard tumor tissue. Here it is. And there is a secondary tumor in the right lung and liver. Here you see the liver and foci of a secondary tumor. And here the secondary tumor on the left side of the picture, but it is right lung. So this particular patient worked in an asbestos quarry, and this kind of pneumoconiosis caused the tumor formation like mesothelioma. Now we go to melanin-forming tissue tumors. Melanin-forming tissue tumors are also benign and malignant kind of tumors. You know, benign tumors, nevi, like junctional, intradermal, compound epithelioid spindle cells, blue nevi, and malignant tumor, melanoma. Synonyms: melanoblastoma, malignant melanoma. It could be in various shapes like nodal shape and surface spreading melanoma. Here on the picture, right picture, we see nevus. Nevus, singular, also spelled like navus, means birthmark in Latin, also called melanocytic, nevocellular, or pigmented lesion. It could be congenital or acquired, benign melanocytic proliferation. Histologically, irrespective of the histological types, all nevocellular nevi are composed of so-called nervous cells, which are actually identical to melanocytes, but differ from melanocytes in being arranged in clusters or nests. Nervous cells are cuboidal or oval in shape with homogeneous cytoplasm and contain large round or oval nucleus. Melanin pigment is abundant in the nervous cells, and it is present in the lower epidermis and upper epidermis, but the cells in the mid-dermis and lower dermis hardly contain any melanin. Look here on the right picture, we see intradermal nervus with nests of the melanocytes. Here you see some such nests. And on the right side of the picture, here we see in dermis, we see nests of melanocytes. Pattern which associated with benign behavior of this kind of neoplasm: small size, circumscription and symmetry, nested proliferation with nests regularly distributed at tips of the rete ridges, melanocyte nuclei smaller than in ingested keratinocytes, uniform cellular density throughout same level of lesion, melanocytes decreases in size towards base of the lesion, and it is due to maturation. So in the benign tumor, if we look at melanocytes under high magnification, we see that on the top of the lesion, they are smaller in their size because they are more mature. But in case of the malignant tumor, we see the opposite tendency, and we will discuss later. Coalescence eosinophilic globules, Camino bodies, are associated with a special kind of nervus, so-called Spitznavi. Absence of mitotic activity is common feature, particularly at the base of the lesion, but sometimes we can see rare mitosis in benign tumors, benign nevi too. Please remember, and it is very important, that there are various histological variants of nevi. Lentiga, it is the replacement of the basal layer of the epidermis by melanocytes. So we see under microscope a lot of melanocytes in epidermis. Junctional nevus is the one in which the nervous cells lie at the epidermal-dermal junction. These nervous cells also form well-circumscribed nests. Compound nevus is the commonest type of the pigmented nevus. These lesions, in addition to the junctional activity, as in junctional nevi, shows nests of nervous cells in the dermis to a variable depth. Intradermal nevus shows slight or no junctional activity. The lesion is mainly located in the upper dermis as nests and cords of nervous cells. Multinucleate nervous cells are common. Spindle cells or epithelioid nervus or juvenile melanoma, all are synonyms for such pathology. It is a compound nervous with junctional activity. The nervous cells are, however, elongated and epithelioid in appearance, which may or may not contain melanin. Please remember, sometimes we see no melanin. Juvenile melanoma is important since it is frequently confused with malignant melanoma histologically. Then goes blue nevus. Please remember this kind of nevus, which is characterized by dendritic spindle nevus cells rather than the usual rounded or cuboid nevus cells. These cells are often quite rich in melanin pigment, and grossly in patients we see bluish color of such nevus. That is why it got such name, blue nevus. Spindle cell or epithelioid nevus or juvenile melanoma. It is a compound nevus with junctional activity. The nervous cells are, however, elongated and epithelioid in appearance, which may or may not contain melanin. As I said before, and blue nevus are also described. Dysplastic nevi are certain atypical nevi which have increased risk of progression to malignant melanoma, and that is very important to remember. These lesions are larger than the usual acquired nevi. They are often multiple and appear as flat macules to slightly elevated plaques with irregular borders and variable pigmentation. Many of the cases are familial and inheritable. Dysplastic nevi have melanocytic proliferation at the epidermodermal junction with some cytological atypia. This picture shows different kinds of nevus, starting from lentiginous melanocytic hyperplasia. In the first picture, we see rare melanocytes in this is border between epidermis and derma, and we see some melanocytes, hyperplasia. Then we see lentiginous junctional nervus here. There are nests of melanocytes here in junction between epidermis and derma. Then lentiginous dysplastic nervus, when we see some atypical melanocytes here. The next stage, early melanoma, when we see atypical cells, and some of the cells goes to the top of epidermis, like here in the picture. And also we see some cells deeper in derma, but the main feature that they are seen in the top, and advanced melanoma with the vertical growth. So the more melanocytes, atypical melanoma, melanocytes on the top, it helps to make right diagnosis of melanoma. And when we see melanocytes deeper in derma, it supports the diagnosis of nevus. Melanoma, the malignant tumor, which has its morphological features, grossly depending upon the clinical course and prognosis, Cutaneous malignant melanomas are of the following four types. Lentigo malignant melanoma. This often develops from pre-existing lentigo, a flat nevus characterized by replacement of basal layer of epidermis by nevus cells. It is essentially a malignant melanoma in situ. It is slow-growing and has a good prognosis. Superficial spreading melanoma. This is a slightly elevated lesion with a variegated color and ulcerated surface. It often develops from a superficial spreading melanoma in situ. Pegytoid melanoma in 5 to 7 years. The prognosis is worse than for lentigo malignant melanoma. Then goes acral lentigous melanoma. This occurs more commonly on the soles, palms, and mucosal surface. The tumor often undergoes ulceration and early metastasis. The prognosis is worse than that of superficial spreading melanoma. Nodular melanoma. This often appears as an elevated and deeply pigmented nodule that grows rapidly and undergoes ulceration. This variant carries the worst prognosis. So remember, the nodular melanoma has worst prognosis for the patient. Histologically, irrespective of the type of malignant melanoma, the following characteristics are observed in tumor. The malignant melanoma, whether arising from a pre-existing nevus or starting de novo, has marked junctional activity at the epidermodermal junction and grows downwards into the dermis. So starting from the junction, grows down. Tumor cells, the malignant melanoma cells, are usually larger than the nevus cells. They may be epithelioid or spindle-shaped, the former being more common. The tumor cells have amorphic cytoplasm and large pleomorphic nuclei with conspicuous nucleoli. Mitotic figures are often present and multinucleated giant cells may occur. These tumor cells may be arranged in various patterns such as solid masses, sheets, islands, alveoli, etc. Melanin pigment might be present, melanocytic, or absent in case of amelanotic melanoma, and there is no any prognostic influence in such case. The pigment, if present, tends to be in the form of uniform fine granules, unlike the benign nevus in which coarse irregular clumps of melanin are present. At times, there may be no evidence of melanin in hematoxylin and eosin stain section, but with Fontana-Masson stain or Dupar reaction reveals melanin granules in the cytoplasm of tumor cells. Immunohistochemically, melanoma cells are positive for HMB45, it's more specific, S100, and Milan A. Also, inflammatory infiltrates sometimes be seen. Some amount of inflammatory infiltrate present in the invasive melanomas. Infrequently, partial spontaneous regression of the tumor occurs due to destructive effect of dense inflammatory infiltrate. Here you see the picture of melanoma. The left side describe the pattern characteristic for melanoma. We see here melanoma cells with fine melanin pigment. As I said before, in case of nevi, we see quartz picture. And also some mitotic figures. The malignant melanoma shows tangential activity at the dermal-epidermal junction. Tumor cells resembling epithelioid cells with pleomorphic nuclei and prominent nucleoli are seen as solid masses in the dermis. Many of the tumor cells contain fine granular melanin pigment. Photomicrograph shows a prominent atypical mitotic figure. Here the mitotic figure. The arrow shows it. Also we see fine granules of melanin within the cytoplasm and within the tissue, and also other mitotic atypical mitosis here at the picture stained with hematoxylin and azine under very high magnification 600. Look here the gross picture of melanoma, melanoblastoma or malignant melanoma. The tumor has the appearance of a plaque rising above the surface of the skin with uneven edges on a wide base with an uneven ulcerated surface. In different areas, the formation has a different color: gray, red, brown, black color of the surface. Here we see the microscopic picture. Melanoma in phase of the vertical growth. Here look under microscope on the top of the epidermis, we see the melanoma cells on the very top, but also we see the growth down the dermis, the vertical growth down the dermis. So here we see the nests of melanoma cells rich with pigment, and here we see a lot of pigment, and the atypical melanocytes growing down the dermis. Now just few words about the tumors of the central nervous system. Tumors of the central nervous system may originate in the brain or spinal cord, primary tumors, or may spread to the brain from another primary site of cancer. And in that case, we'll call them metastatic tumors. More than 1/4 of the central nervous system tumors are the secondary metastases arising in patients undergoing treatment for systemic cancer, various kinds of cancers. Primary central nervous system tumors are the second commonest form of cancer in infants and children under the age of 15 years old, exceeded in frequency only by leukemia. So leukemia is the first tumor for children, and central nervous system tumors is the second cause of the neoplasia in children. Both benign and malignant central nervous tumors are capable of producing neurologic impairments depending upon their site. Primary tumors or intracranial tumors include tumors arising from constituent cells of the brain, with the sole exception of microglial cells, and from the supporting tissues. Childhood brain tumors arise from more primitive cells like neuroblastoma, medulloblastoma. So here the nomenclature and classification of the tumors of the central nervous system. Tumors of neuroglia or gliomas, astrocytoma, oligodendroglioma, ependymoma, choroid plexus papilloma. Tumors of neurons, neuroblastoma, ganglioneuroblastoma, ganglioneuroma. Tumors of neurons and neuroglia, ganglioma. Poorly differentiated and embryonal tumors, medulloblastoma, neuroblastoma, PNEAT tumor. Tumors of meninges, meningioma, meningeosarcoma. Nerve sheath tumors like schwannoma, neuralimoma, neurofibroma, malignant nerve sheath tumor. Other primary intraparenchymal tumors like hemangioblastoma, primary central nervous system lymphoma, germ cell tumors. Also, miscellaneous tumors like malignant melanoma, craniopharyngioma, pineal cell tumors, pituitary tumors. And also, you must know tumor-like lesions like epidermal cyst, dermoid cyst, and colloid cyst. And also, as I said before, secondary tumors quite common for the central nervous system, and there are metastatic tumors with various primary tumors, various primary cancers. The anatomical distributions within the brain, so the common intracranial tumors. We see here meningioma, tumors from meninges. They are always close to the cranium, and so quite easy for surgery compared with the other locations. Glioma within the brain, astrocytoma often on the here we see astrocytoma pinealoma, ependymoma, various kinds of neuromas, pituitary adenoma, craniopharyngioma, medulloblastoma. So these are the most common intracranial distribution of the tumors. Now, this is the end of my presentation. Thank you very much for your attention.